Very good morning to everyone. So today we'll be continuing the class on conjunctiva. I hope amidst all this coronavirus holiday and stuff, I hope you remember at least a bit of what we have tried to learn in conjunctiva. So today we'll be discussing a very important topic, that is trachoma. So coming to Chlamydia trachomatis, if at all you remember anything about your microbiology, Chlamydia trachomatis has been recently been classified as a bacterium. And now coming to the most important part, Chlamydia trachomatis can cause trachoma, which is a chronic keratoconjunctivitis. So trachoma currently has about 12 serotypes, and these serotypes, especially A to C, they cause a very severe form of trachoma, which is known as the hyperendemic trachoma. Okay, and then from serotypes D to K, they form paratrachoma. These paratrachoma, it also causes what is known as neonatal inclusion conjunctivitis, which is nothing but your ophthalmia neonatorum. I hope you remember that. And then also adult inclusion conjunctivitis. So the main serotypes causing infections in humans are from A to K, A to C causing hyperendemic trachoma, and from D to K causing paratrachoma, also known as the neonatal and adult inclusion conjunctivitis. All right. Now, also, this chlamydial conjunctivitis can be classified by the Jones classification. This Jones classification is again similar to the classification which we saw previously, where the serotypes from A to C form the blinding trachoma or the hyperendemic trachoma. Okay, so this trachoma is mainly transmitted by way of eye to eye, by way of ocular discharge. The non-blinding trachoma is also caused by serotypes A to C. Okay, but this is a milder form of the disease. Now, paratrachoma, as we've already seen, it is from serotypes D to K, and this is mostly from genital infection, which is spread to the eye. Okay, so now the classification which you have to remember and the agents which you have to remember is this table which is given in your textbook. This is very important. Okay, now what is trachoma? If you remember, the word kerato suggests cornea. So this is a chronic keratoconjunctivitis. So it affects the superficial epithelium of the cornea as well as the conjunctiva. Again, just to remind you, keratos is nothing but cornea. Trachoma is one of the leading cause of preventable blindness. Please remember, trachoma accounts for one of the leading causes of blindness, second only to cataract. Okay, so it is the second most common cause of blindness. In Greek, the word trachoma itself means rough. Because of the disease trachoma, the conjunctiva and the cornea is affected, which disturbs the very smooth surface of the conjunctiva and the cornea, adhering it a rough surface. So in Greek, the word trachoma itself means rough. So this trachoma has both a follicular response as well as a papillary response. Now, if you remember, again, as in our earlier classes, if you remember even a bit, follicles were more common in viral conjunctivitis, especially in the lower part, and papillae was associated with allergic conjunctivitis, and this was more common in the upper palpebral conjunctiva, right? Now, again, just trying to go back to the etiology. Trachoma is caused by Chlamydia trachomatis, and what is the most common source of infection? Source of infection is the conjunctival discharge of the affected person. Or suppose there is a superimposed bacterial infection, that is a secondary infection. This secondary infection will obviously lead to more mucopurulent discharge or purulent discharge, and this will further hasten the process of infection. So we need to remember that this conjunctival discharge is the primary source of infection. Now, coming to the modes of infection, this trachoma is primarily spread by either airborne or waterborne modes, and then also very important, especially in endemic areas and where there is overcrowding and unhygienic conditions, there is abundance of fly population. So vector transmission by flies is also very, very important. Then there is also transfer. I'm sorry, that's a spelling mistake. It's not maternal, it's material transfer through contaminated fingers. So just putting your fingers in your eyes with trachoma and then again touching some other person with the same fingers, or even sharing bedding, sharing handkerchiefs, sharing towels, or sharing the common kajal sticks or mascara, whatever, sharing all these common stuff will also lead to spread of trachoma. Now, what about the common predisposing factors in trachoma? So trachoma can essentially occur in 2 stages. Please remember, phase of active trachoma as well as a cicatrizing stage or a scarring stage. So active trachoma, usually it starts in infancy and childhood, but it can affect any age. Trachoma can affect any age, but typically it starts during childhood. Okay, and there is a female preponderance, and race, it is very common in Jews and not so common in Negroes. Now, climate. Any dry weather, any dusty weather, any abundance of dust, abundance of smoke, abundance of sunlight, abundance of irritants, which may be physical or well as chemical, all these can lead to form a major risk factor for trachoma. Okay, and coming to socioeconomic status, it is more in poor classes due to unhygienic conditions, and also when there is overcrowding or unsanitary conditions. Anything where there is scarcity of water, people don't maintain proper hygienic practices, there is abundance of fly population. All these will lead to forming a major risk factor for development of trachoma in that particular area. Now, coming to the prevalence, trachoma is commonly seen worldwide. It is worldwide in prevalence, but more so common, especially in North Africa and in Southeast Asia. Again, as I said, it forms 15 to 20% of the world's blindness. So that is a major chunk, second only to cataract. Okay. Now, as I said, the clinical features of trachoma can be classified into 2 major parts: phase of active trachoma as well as the phase of cicatricial trachoma. Now, phase of active trachoma. Again, as I've already spoken earlier, this phase of active trachoma occurs in childhood and it is insidious or subacute in onset. So it doesn't present acutely. There is no acute presentation of sudden severe discharge or anything like that. So it is a very subacute presentation, and the incubation period is commonly from 1 week to 2 weeks. Okay. Now, when there is only purely trachoma and there is no other associated secondary bacterial infection, how does the patient present? He can be totally asymptomatic, or he can just have mild foreign body sensation or some lacrimation, some stickiness of lids, and some scanty discharge, mucoid discharge. Please, it's not going to be mucopurulent or purulent. No, it is just some scanty mucoid discharge with slight stickiness of lids and some watering. That's it. Because the presentation is so scanty or so mild, so you're doubtful whether the patient has trachoma or not. So for that very reason, when there is no superimposed bacterial infection, it is referred to as trachoma dubium. Okay. Now, suppose the same patient, along with being infected with chlamydia trachomatis, also has a secondary bacterial infection with some other bacteria. Could be staphylococcus, streptococcus, pneumococcus, anything. Suppose he has the secondary bacterial infection, then obviously he will have other features. So then he would not present with typical symptoms of trachoma with such mild symptoms. He will have symptoms of bacterial conjunctivitis, very similar to acute mucopurulent, where he'll have mucopurulent discharge, redness, foreign body sensation, and everything else, photophobia, stickiness of lids when he wakes up in the morning. So you have to differentiate between these two. Now, what are the signs of active trachoma? Again, as we remember, active trachoma occurs when the patient is in his childhood phase. So typically when the patient is a child, what all active features of trachoma can occur? So typically we divide them into conjunctival signs as well as corneal signs. So what are the conjunctival signs? We'll go line by line. So first of all, again, trachoma is a disease which typically affects the upper tarsal conjunctiva. So conjunctival condition or redness is typically seen in the upper tarsal and the pharyngeal conjunctiva, that is the superior fornix. Okay. Now, look at this picture which I've put on the right. Those are the typical follicles. As you can see, they are whitish, they appear slightly raised, and the typical appearance is referred to as being similar to boiled sago grains. So, conjunctival follicles are typically described as being similar to boiled sago grains. Again, the location, please remember, trachoma typically affects the upper tarsal conjunctiva. So, the follicles and papillae, everything is typically seen in the upper tarsal conjunctiva. Now, please remember, papillae in allergic conjunctivitis are seen on upper tarsal conjunctiva, and viral conjunctivitis, follicles are seen on lower tarsal conjunctiva. Alright? So, now conjunctival follicles, these are typically seen on the upper tarsal conjunctiva, and please remember, this is not the only location. It is typical of in upper tarsal, but it can also be seen in other locations such as the bulbar conjunctiva, sometimes even the lower fornix, lower conjunctiva, lower palpebral conjunctiva. Okay. Now, look at this black and white picture at the bottom. Now, this black and white picture typically shows what a follicle is typically made up of. So, you can plainly divide this follicle into three parts: the central core area, surrounded by a cortical area, and the most peripheral area. So the central or the core area typically contains three types of cells. One is the lymphocytes. Other, please remember, is the multinucleate giant cells, that is the Leber cells. Leber cells are multinucleate, and there is also mononuclear histiocytes. I repeat again, there are lymphocytes, there are Leber cells which are multinuclear giant cells, as well as mononuclear histiocytes. All these will form the core. And surrounding this core, there is a cortex. This cortex consists of lymphocytes only, and these lymphocytes are in a phase of active proliferation or active maturation stage. So there is lots of proliferation activity going on in the cortical part, which consists of lymphocytes. Again, looking back at the black and white picture, we finished the core part, we finished the cortical part. Surrounding the cortical part in the most periphery are the blood vessels. So this accounts for the whitish appearance of the lymphocytes, because the blood vessels are in the most periphery. The center part consists of mainly of lots of cells, mononuclear histiocytes, multinuclear Leber cells, as well as lymphocytes. So all these will account for the whitish appearance of the follicles. So these are your follicles. They look white and similar to boiled sago grains. Now, coming to papillae. Papillae was a topic which was touched upon, and I hope you understood when we spoke about it in allergic conjunctivitis. Papillae are reddish, flat-topped, raised areas. If you remember, in viral conjunctivitis, we spoke about it being similar to cobblestones. So again, in the same manner, even in trachoma, there are flat top. They are raised, but they are not like a dome shape. They are flat top, like a plateau. So these conjunctival papillae, they are responsible for the reddish and velvety appearance. Now, in stark contrast to the composition, in follicles, the blood vessels were in the periphery. You can see in the black and white picture at the bottom, in follicles, the blood vessels were at the periphery. But in papillae, please remember, these are reddish in color and they're responsible for the red and velvety appearance of the conjunctiva. Here, the blood vessels, they are in the center. So it consists of a central core of blood vessels and surrounded by other lymphocytes. And you can see in the picture, it is covered by an conjunctival epithelium, which is of hypertrophy. So central core of blood vessels surrounded by lymphocytes covered by hypertrophied epithelium. Now, what are the corneal signs? See, again, as I said, the conjunctiva and the cornea are in anatomical continuity. So when the upper tarsal conjunctiva is affected, it is so possible that even the cornea can be affected, and so there can be superficial keratitis which can be present in the upper part of the cornea. So again, the anatomical location should not be a confusion, because the superior part of the conjunctiva is involved. The cornea will definitely be affected in the superior part. Now, what are Herbert follicles? So similar to conjunctival follicles, these Herbert follicles are nothing but raised whitish areas which are present in the limbal area. So these are given a specific term known as Herbert follicles. Now, this is a very important picture. Now, as you can see, this is something called PANNUS. So that's a very beautiful picture which is present even in your textbooks. So what is PANNUS? PANNUS consists of two important parts. One is infiltration and other is vascularization. So all these infiltration of cells as well as vascularization. Please remember, cornea is in a vascular structure. So but here the cornea is being vascularized because of all the irritation being caused by the chlamydial trachomatis antigen. So PANNUS consists of vascularization as well as infiltration. Now, please look at the picture. Whenever you see PANNUS, you have to be able to identify whether the PANNUS is progressive or regressive. Now, just look at those two pictures. In that picture labeled A, here you can see the cells are ahead of the vascularization. That is, whenever in progressive, please PIV, that is how I remember. If you can come up with a better mnemonic or something to remember, it's up to you. But in progressive, infiltration is ahead of vascularization. You have to infiltrate first, so that is progressive. In regressive, it's the other way around. Vascularization is ahead of infiltration. So you have to remember one, and the other one is obviously reverse. So, and the adjacent picture shows a beautiful picture of PANNUS. So when there is the phase of active trachoma, obviously the PANNUS will have to be progressive, not regressive. So in the phase of active trachoma, you have progressive PANNUS. Now, what about ulcer? Now, I think we are good with the conjunctival signs. We had congestion, we talked about conjunctival follicles, and we talked about conjunctival papillae. So those are the three signs: congestion, follicles, and papillae. Now coming to the corneal signs, we had superficial keratitis, we had Herbert follicles, and then we had progressive PANNUS. And suppose the superficial keratitis progresses and even the PANNUS is developing, sometimes an ulcer might develop in the corneal area. So a corneal ulcer might also develop. Now, what happens in the phase of cicatricial trachoma? So in the phase of cicatricial trachoma, it usually occurs after a long time. It usually occurs in the middle age of the patient. So in cicatricial trachoma, you will have all signs of scarring and healing of the conjunctiva and cornea. So what all can happen in the phase of cicatricial trachoma? In conjunctival signs, you have scarring, concretions, pseudocyst, xerosis, and symblepharon. Xerosis is nothing but dryness and lusterlessness of the conjunctiva. What is symblepharon? Whenever adhesions develop between the bulbar conjunctiva and the palpebral conjunctiva, it is known as symblepharon. Okay. Now, this is how conjunctival scarring looks. So whenever you just invert the palpebral conjunctiva, you can see all those whitish fibrous bands in the conjunctiva. So that is known as conjunctival scarring. So it can be any type. It can be irregular, it could be star-shaped, or it could also be linear. Now, what is Arald's line? Whenever in the sulcus subtarsalis, that is 2 mm from the lid margin roughly, you can see a linear scar in the sulcus subtarsalis, that is known as the Arald's line. Now, concretions is a very important topic. It is a very important 2 marks questions, you can say. So whenever there is lot of accumulation of dead epithelial cells, because this is a keratoconjunctivitis, so there is lots of accumulation of epithelial cells as well as mucus in the conjunctiva. All these will lead to very hard, such pinpoint raised areas known as concretions. They cause lots of foreign body sensation, and they also cause irritation, and so sometimes they also cause corneal punctate keratitis. So all these concretions can lead to foreign body sensation, and they are a main complication of trachoma. So conjunctival signs include scarring, concretions, xerosis, and symblepharon. Now, what are the corneal signs? Again, as I said, active trachoma had progressive pannus. Here we have regressive pannus, where vascularization is ahead of infiltration. And in active phase, we had Herbert follicles. Now, if these Herbert follicles in the limbal area heal, we will have oval or circular scars known as Herbert pits. What all complications can occur? Corneal opacity can occur, where there is scarring of the cornea. Corneal ectasia can occur, where there is thinning of the cornea. Corneal xerosis can occur, where there is dryness of the cornea, or a total corneal pannus can occur. Now, what are the lid signs? Now, coming to the lid signs, which can occur in the cicatricial phase of trachoma. What is trichiasis? Trichiasis is nothing but interning of the eyelashes. What is stylosis? Stylosis is thickening of the lid margin. Entropion is inward turning of the lid margin. Ptosis is drooping of the eyelid. Mederosis is loss of eyebrows or eyelashes. And ankyloblepharon is nothing but adhesions between two palpebral conjunctiva. Again, just for repetition's sake, trichiasis is interning of eyelashes. Stylosis is thickening of the eyelid. Entropion is inward turning of the lid margin. Ptosis is drooping of the lid. Mederosis is loss of eyelashes or eyebrows. And ankyloblepharon is adhesion between the two palpebral conjunctiva. Now, what are the lacrimal apparatus sequelae? They include chronic dacryocystitis and chronic dacryoadenitis. That is, infection of the lacrimal sac and infection of the lacrimal gland. Gland is dacryoadenitis. Now, these are two classifications which are important. One is Macallan's classification and WHO classification. The more important classification is the WHO classification or FIXTO. Trachomatis inflammation, follicular, intense, scarring, trichiasis, and corneal opacity. Now, very, very self-explanatory classification. This part, I'm sure you can go through this classification. Now, again, these are a few common pictures. The first picture shows follicles. The second picture shows a pannus. The third picture shows scarring. The fourth picture shows an Arald's line. And then you have Herbert pits, and obviously it is entropion in the last picture. The last picture is so typical, it's an entropion, okay? Now, again, similar pictures. There is trichiasis, there is corneal opacity, and also a severe corneal opacity picture. Now, how do you diagnose trachoma? Again, as I said, the clinical grading, clinically, if you have to diagnose trachoma, you look for all these signs and symptoms, as well as you will go through the WHO classification and try to classify trachoma according to the WHO classification. Now, how do you diagnose in the laboratory? Obviously, you will go for conjunctival swabs, and then you will send them for Ginza stain smears. You can also try to detect chlamydial inclusion bodies, and also you can do ELISA for chlamydial antigens, PCR, and also you can do isolation by using yolk sac inoculation method or tissue culture techniques, and also serotyping. So you go for cytology, inclusion bodies, PCR, ELISA, and isolation and serotyping. Okay. Now, two main important differential diagnoses of trachoma. Again, very, very simple. Trachoma has follicles and papillae. So where else do you see follicles and papillae primarily? Follicles are typically seen in viral conjunctivitis. So when you see follicles, you have to differentiate it from adenoviral conjunctivitis. And when you see papillae, you have to differentiate it from vernal conjunctivitis or spring catarrh. So these two form the main important differential diagnosis. Now, management. Management includes treatment of active trachoma, that is topical therapy. In active phase, we'll go for tetracycline or erythromycin eye ointment twice daily for 6 weeks. Or systemic therapy will also include tetracycline or erythromycin QID for 4 weeks, or doxycycline, or the current most advocated is azithromycin orally. So we can go for tetra or erythromycin or doxy or azithro. Combined therapy will combine both topical and systemic, especially when there is severe ocular disease or when there is associated genital infection. Now, how do you manage cicatricial trachoma? You need to remove concretions. Usually you do it with a needle under topical anesthesia. In trichiasis, the inward turned eyelashes are removed by epilation or electrolysis. And if there is entropion, we go for surgical correction. And we go for lubricating drops in case of cirrhosis or conjunctival dryness. Suppose there is a corneal opacity formed, we need to replace the cornea with a penetrating keratoplasty where a full thickness corneal graft is placed, or a keratoprosthesis where an opening is created in the cornea and a prosthetic device is inserted. You can Google the pictures. Now, trachoma is leading cause of preventable blindness, so it's better to prevent than cure. So what is the strategy adopted for prophylaxis? The World Health Organization has adopted the SAFE strategy for trachoma blindness, which is nothing but surgery to correct eyelid deformities, A for antibiotics, F for facial hygiene, and E for environmental changes, that is maintaining your hygiene and sanitation and water and eliminating the fly population. So all this is the management part. I hope trachoma, you can immediately go through your textbook, you'll almost find the same thing conveyed. It is better to read trachoma in one go and finish it off. And please read the treatment part and the SAFE strategy especially, and please do not confuse the conjunctival signs and the corneal signs, and please do not confuse the anatomical locations, whether it is the upper half or the lower half, okay? Now, adult inclusion conjunctivitis is also caused by chlamydia trachomatis. It is associated with a follicular conjunctivitis associated with mucopurulent discharge. Now, chlamydia trachomatis serotypes D to K. Please remember when we did hyperendemic trachoma, it is from serotypes A to C. This is from serotypes D to K. So serotypes D to K, if you remember, was not eye to eye transmission. It was from genitals to the eye transmission. So the primary source of infection is urethritis and cervicitis, and the primary source is contact with fingers, or also please remember it is known as swimming pool conjunctivitis. Now, adult inclusion conjunctivitis will have symptoms similar to mucopurulent conjunctivitis, but apart from having conjunctival hyperemia, there is lots of follicular hypertrophy, predominantly in the lower part. But please remember, superficial keratitis here is in the upper half. So, adult inclusion conjunctivitis has symptoms similar to mucopurulent conjunctivitis, along with follicular hypertrophy in the lower part and SPK or superficial keratitis in the upper part. Again, this sometimes has preauricular lymphadenopathy, okay? Now, treatment is again very similar to trachoma, where you have tetracycline eye ointment. Systemic is again tetra or erythromycin or doxy or azithromycin. So these 4 drugs will be there. Apart from that, because this infection is spreading from genitals to the eye, it is important to refer to the patient to a genitourinary specialist, as well as examination of the sexual partner is mandatory, okay? Now, we'll do a very random topic known as subconjunctival hemorrhage, also known as ecchymosis of conjunctiva. So as you can see in the picture, it can range from a very small petechial hemorrhage to an extensive one. Most of the time, it is a cause of concern for the patient, but not so much for the ophthalmologist. Most of the time, it is trivial and there is not much to worry about. Subconjunctival hemorrhage, also known as ecchymosis of conjunctiva. Now, what are the etiologies? There are a lot of etiologies of subconjunctival hemorrhage, but the most common one is trauma. Either a punch from a fist or a ball, or sometimes surgeries, or sometimes injections given during surgeries, like subconjunctival and retrobulbar, or inflammatory viral conjunctivitis, or pneumococcal conjunctivitis, or sometimes when there is sudden strangulation or any crush injuries of thorax and abdomen, what happens is there is sudden increase in pressure in the conjunctival capillaries and they start to rupture. Or sometimes the patient may have fragile capillaries like in diabetics and hypertensive, or there could be anemias, leukemias, purpura, hemophilia, or malaria, typhoid, and very rarely there is vicarious bleeding which is associated with menstruation. So all these form the etiologies of subconjunctival hemorrhage. Now, what are the clinical features? Usually there is nothing much. You can see there is just a flat sheet of blood which is homogeneous and which is bright red in color. Apart from that, there is nothing much. The patient has no other symptoms. Suppose if the injury is just to the eyeball, then you can see the limit of the subconjunctival hemorrhage all over. But suppose there is a head injury or there is some injury to the orbit, then you cannot limit or you cannot see the limits of the subconjunctival hemorrhage. But whatsoever, any subconjunctival hemorrhage will be absorbed usually completely within 7 to 21 days. And during the course of this absorption, the subconjunctival hemorrhage will start changing colors from red to orange to yellow. Okay. So what is the treatment of subconjunctival hemorrhage? There is no specific treatment for subconjunctival hemorrhage. You can prescribe some lubricating eye drops, some cold compresses. But the most important thing which you can do is reassure the patient. Reassure the patient that nothing is going to happen and this subconjunctival hemorrhage will take some 2 to 3 weeks to get completely absorbed. That is the most important thing. And just for like a placebo therapy, you can prescribe some lubricating eye drops to the patient. Now, one more important topic is discoloration of the conjunctiva. So, as you can see, the conjunctiva is normally a translucent structure with the white sclera underneath. But sometimes this conjunctiva can develop certain colorations. As we have already seen, the subconjunctival hemorrhage, it develops a red color. Now, suppose the patient has jaundice or sometimes in malaria, then the conjunctiva will appear yellow, as you can see in the picture below. Suppose the patient, especially no prejudice, but suppose it's females, they keep applying kajal or mascara on a daily basis and they don't maintain proper eyelid hygiene. They don't remove the mascara or the kajal properly. Then you can see in the first picture, there is a grayish discoloration of the conjunctiva due to accumulation of all that kajal and mascara pigments. Now, in the second picture, what is argyrosis? Argyrosis is nothing but sometimes the patient uses silver nitrate drops for a long time, and this argyrosis will cause a brownish gray pigmentation, especially in the lower fornix part. So that is argyrosis. Now, what happens when does a patient develop blue conjunctiva? Suppose the patient for some cosmetic purpose gets some ink injected into his under the conjunctiva. So he gets a tattoo, then he develops a blue conjunctiva. Okay. Now, sometimes the conjunctiva also appears blue, but it might not be necessarily due to a conjunctival disease part. Sometimes the patient has blue sclera, and because of the conjunctiva overlying the sclera, the patient might have blue appearance, but it is a pseudo appearance. So main cause would be either an ink tattoo or some manganese dust. Now, when does the patient have brown appearance? See, brown appearance can have two main causes, which are non-melanocytic and melanocytic. The patient has Addison's disease, or he uses adrenaline for glaucoma treatment for a long time. Then he can develop such brown pigmentation in the conjunctiva. What are the melanocytic causes? Suppose the patient has a nevus, which is benign, or he can have a malignant melanoma type of growth, or he can have melanosis, which is just pigmentation developing right in the childhood. It is stationary and usually it is not of concern. So all these causes can lead to brown color pigmentation in the conjunctiva. Okay, so non-melanocytic and melanocytic causes. Now, the last topic, a small one. This is important because as of now it is growing a bit. So ocular squamous surface squamous neoplasia is again an important topic where just similar to the other parts, you have changes involving the epithelium of conjunctiva, cornea and limbus. So there are lots of dysplastic changes and it includes three main parts. squamous dysplasia, carcinoma in situ, and squamous cell carcinoma stage-wise. In squamous dysplasia, you have dysplasia of certain cells. In carcinoma in situ, it has involved all the epithelium, but there is no breach of the basement membrane. The basement membrane is intact. In squamous cell carcinoma stage, it has penetrated the basement membrane and it has invaded the stroma. Now, risk factors for ocular surface squamous neoplasia include UV light exposure, advanced age of the patient, smoking, immunocompromised patients like AIDS infections and also human papilloma virus infections, any prior history of squamous cell carcinoma in the head and neck, patients with fair complexion or light complexion, and xeroderma pigmentosa patients. Now, what is the main pathogenesis? The predisposing factors like UV light exposure or advanced age or fair complexion or any immunocompromised patients, all these predisposing factors will start acting on the stem cells at the limbus, and these cause abnormal proliferation. Okay, so stem cell theory is the main advanced theory for ocular surface squamous neoplasia. So there are three morphological patterns, as you can see: a leukoplakic form, a gelatinous form, and a papillomatous form. And over time, you can see the third picture, a nodular form of squamous cell carcinoma might also appear. So what is the treatment of squamous surface neoplasia? We'll go for surgical excision with the surrounding 2 to 4 mm of normal tissue. And you can also supplement it with cryotherapy as well as topical chemotherapy with mitomycin C. And advanced cases, you can go for radical excision, enucleation, which is removal of the eyeball, and exenteration, which also involves removal of the orbit, supplementing with post-op radiotherapy. So this is all we have for today. So we finished trachoma, we finished subconjunctival hemorrhage, discolorations of conjunctiva, and ocular surface squamous neoplasia. So try going through them. I know it is tough, but to learn like this, but still I hope you'll put in some effort and just finish off these classes. In the next class, we'll be covering pterygiums, that is your degenerations, and probably xerophthalmia. So thank you so much. Thank you.